speakers, Bhavana and Margale Rodriguez. And I welcome you, both of you, to the Indian Congress of Pharmacy Practice 2020 and the fourth annual convention of Indian Association of Colleges of Pharmacy. Myself, Dr. T.V. Narayana and Dr. Dhanbal, directors of ISCP, on our behalf and on behalf of our beloved President, Professor K. Chinnaswamy, and our patron and mentor, Dr. B. Suresh, and other office bearers of ISCP, we welcome both of you for the technical session track 1 of this annual convention. And I'm very happy that Ms. Bhavana is going to deliver talk on medication therapy management in pharmacy practice. And Ms. Margali going to deliver talk on future of pharmacy, science and technology, the answer. And the information, for your information, the session is for 30 minutes and 25 minutes is time slot allotted for your talk and 5 minutes for question and answers. So only we'll select some questions from the chat box and we will send it to you. 3-4 questions we'll ask. And remaining questions we'll send it to you by mail, where we will upload the answers given by you to the website of our ISCP. So with this welcome, I request our director of ISCP, Dr. Dhanbal, to give brief introduction and continue further proceedings.
Thank you, Chair. So it's my proud privilege to introduce the third speaker of this track session of ISCP convention, Ms. Bhavana Mutha. Ms. Bhavana Mutha is a 20-year veteran in the field of pharmacy and loves to serve as a passionate and compassionate pharmacist. She has an incredible journey to share and stories to tell. She has several published articles in the Pharmacy Times, Drug Topics, SDN, and serves as a member of an advisory board with the Pharmacist Moms group in collaboration with the Pharmacy Times. Fortunate to have seen the best of both the worlds, her vision is to pursue a role as global leader in visioning global health. Her message to fellow pharmacists is learn, apply, imply, think outside the box, and think clinical. So with this short introduction, may I request Ms. Bhavana Mutha for her presentation on the topic medication therapy management in pharmacy practice. Over to Ms. Bhavana. Thank you.
All right, thank you so much. I will have to ask, is my screen visible and then am I audible?
Yes, please. Yes.
All right. So my computer tends to freeze up because it's a touch screen. So just in case if you run into any situational issue, please just jump in. We have a copy of my presentation with one of the member of the organization committee. So to start off, it's so nice to just roll in, from what Dr. May said, evidence-based medication. And then Chris Alderman put, reviews on all the specialist practice in pharmacy. To introduce myself a little bit differently, I grew up in India for about 25 years, learning the traditions, ancient cultures, and everything that aligns with India. And then I came to US, where I was able to pursue the passion of practicing pharmacy. In other words, I look at myself standing with a different position who is capable to look at the better vision of both the worlds. And there's a large community practicing of the doctors or the pharmacists in the United States who are like me, myself. In terms of my professional background, 15 years of community practice, and I grew up with this medication therapy management practice ever since it was in its baby stage. It has been an important impact in my life, and I love practicing MTM in pharmacy practice. To start off, if you look at my first slide, in the actual setting of the practice, every difficulty, hardship, or negativity that I faced, I put them as a foundation of those stairs that you look going up. And that's how I see that MTM can play a very big role as a community pharmacist in a patient's life. In 2007, my company that I was working for initiated training in medication therapy management. Of course, me being the nerdy person, I wanted to jump in and learn every single thing that came my way. After the training, there was a situation where I was going to do my first MTM call. I had to go and visit the patient in her house, which was about 15 miles from my household. I was super excited to do my first house call. And as I walked into this patient's home, I see some blood spattered on the carpet. It took my attention, and I just wondered what was wrong. I could not wait to put all the medications together for this patient and see what actually was wrong. And here comes performing my CMR for this patient. I see that this particular patient was on a combination of drugs that should have been totally avoided. And that was it. In the year of 2007, MTM became my mindset in the community practice that I always did in last 15 years. The next slide, I see, I'm just dissecting our PharmD and vision, mission, and action together can make a unique difference to the field of pharmacy. Looking at our curriculum, our PharmDs coming out can either go into the programs of life sciences and come out with the mindset of being a scientist or work in the industry. The other aspect is clinical pharmacist, and they end up working into hospitals or retail. Ultimately, this will put you into giving a global presence in terms of the pharmacy world. And it's so amazing that I hear from all other dignitaries, and having practiced in the United States and having grown up in India, I understand the actual needs of a pharmacy profession across the globe. The next thing I want to focus on is collaborative team. Now, if you look at my slide, you will see collaborative team talks about doctors, nurses, pharmacists, and that additional person in the picture is patient. And I love that part when the patient himself takes the role on being a part of the collaborative team. A collaborative team can be reasonably playing a very big role in creating a healthy nation. The example that comes to my mind is think about your body, your heart, your lungs, every single organ, your liver, your kidneys inside the body are talking to each other every single minute. And even if one person stops talking to the other person, it's in havoc on the body. And that's exactly how I visualize the collaborative team. The team of the doctors, nurses, pharmacists, and patient ultimately forms the complete picture, and which puts a patient into a healthy situation. And as we all say, you look at the debit card in the back, as we all say, healthy patient is, health is wealth, healthy patient contributes to higher productivity and higher and healthy patient. The next one I talk about health hygiene, health literacy, and RX impact. It seems like a hefty vision and a Herculean task, but a pharmacist, trust me, can play a very, very big role in developing the rural biomes. Even the basic health hygiene literacy can make changes and wonders in how we can have development in the rural biomes. To institute that in practice, we want elements like MTM, CPR, immunization, a strategic step approach. And if we were to execute that, it could be any country. In the United States, we are already practicing all of this. I see an execution timeline of about 5 to 10 years. Remember, passion paves the way. And if the passion is high, your naysayers are going to become your torchbearers to take the program ahead. The next slide I'm going to talk about is acronyms. And when I made this slide, the visualization I had in my mind is, wouldn't it be cool that across the globe, every single person uses common terminology like CMR, PML, MAP. And so if a person was traveling in between different countries and they were going to go through medication therapy management review, this would be the terms that the pharmacist would use to describe the patient situations. PML, to begin with, is one of my favorite ones. This is the groundbreaking start where we can guide our patients to make those personal medication lists. SBAR and SOAP. SBAR is something that, in simple terms, I would say is a language used between the doctors and the nurses. SOAP is something we always used in terms of medication therapy management when we reported a patient's complete study. The next thing is intervention, documentation, and follow-up. If I look at that word documentation, an old adage comes to my mind. If you did not document, it did not happen. And so documentation is of utmost importance. It's the most important element when you're doing a CMR or MTM. DTP is how I visualize my future of tomorrow. If this peer pharmacists are talking about a patient, they would be utilizing those terms to say, hey, this is the DTP that I figured in this particular patient. Of course, we have a lot of work in developing the EHR, electronic health records. And I see a lot of companies getting involved in developing those kind of platforms and digitalizing patient health. So that becomes like a blueprint of patient's health from where you can take decisions or present it to your doctors. Now, in this slide, you look at the 100% role players. A whole circle is filled with the clinical pharmacist, of course, in collaboration with MD and nurse providers to form a care plan team. What comes to my mind is, as a clinical pharmacist, you're in position to take or field any questions that could be coming to you from the industry or from the doctors. And this is how I put it in a very simplistic manner and an interesting manner. Radiology, oncology, nephrology, neurology. Talk about any of these logies, drug makers to drug takers. You are in the position to disseminate that knowledge that you're learning through your curriculum. And of course, that is to be combined with the doctors and the nurses as one team. If you look at this particular chart here, you see that nurses have their own scope of practice. MDs are overloaded with paperwork. There is so much that they already have. If you try to go and be in their shoes, you'll find it burning. And so as pharmacists, we are in such a great position to unload and distribute that workload when it comes to the patient health. Now, when I talk about MTM, this might be a new concept for us in India. Why is it important? Who are the people benefiting from that? Research and studies show that for every dollar that is invested in performing an MTM, there is an ROI between $7 to $12. 12 would be the higher end of it. It shows that it causes overall benefit reduction to the healthcare cost. How is this important to the patient? Patients are going to use learning the medication in a more beneficial and a cost-effective manner. When I say beneficial, a simple factor that if the patient's taking the medication in the morning or on an empty stomach matters on the absorption and the efficacy of the drug into the patient's system. Let's look at our doctors. How are we going to be important to our doctors? As pharmacists and clinical pharmacists, we cannot demand respect. All we can do is earn respect with the knowledge that we have. Tell our doctors we're standing right behind them. So for us, when we're talking to our doctors, you become an oversight. You're not somebody who's looking up on their shoulders, but you're watching out. They say to err is human. And this gives you a perfect position. You're able to find out any possible mistakes or any recordings that were missed in the patient's chart. So verification of information that may be missing and spotting errors in patient records. Of course, as pharmacists, you're in great position to provide drug therapy education. So looking at that, what is the philosophy of MTM? Everybody's providing care. Why is this different? And these three elements are my favorite ones because this is patient-centered rather than product-centered, number one. You focus on the entire profile of the patient rather than one single medication. And the last one I love is an entire care team involved. To simplify with a simple example, a patient calls a doctor about having a headache. The doctor will give a suggestion that either Tylenol or ibuprofen would be good for your headache. The patient decides to go out and take ibuprofen. And this was all empathy-based care. Doctor did his role. Now what happens is in this whole process, maybe the doctor didn't have access to the patient's other lab work, and comes out that the patient had some kidney issues and ibuprofen would not be something that the patient should be continuing. So when you're in a position to look at the entire profile of the patient, you are able to nip those problems that would arise from taking inappropriate medications. When I talk about outcomes, increased adherence, this is a very simple example. Even when I talk to my family back home many times, blood pressure medications, people will take it for some time thinking, oh, I'm fine and I don't need this anymore. But if a pharmacist is involved in explaining the importance of blood pressure medication and why you need to take it, it has been shown that it has increased the adherence. Increase patients' understanding, and I'm going to circle this part, self-management skills. Nobody can do anything until the patient himself is involved in making that change for his health. And that's why as pharmacists, by educating the patient, you put them in the position to self-manage their disease states. This helps reducing preventable adverse event cost, reduction of medication-related morbidity and mortality. If I were to bring numbers, you'd be surprised how many people are rehospitalized from adverse drug reactions itself. So it will help you reduce the healthcare cost due to duplicate or unnecessary prescriptions. Duplication becomes so common when there is polypharmacy or when you're not satisfied with one doctor and you go see another doctor. It is something simple that can be avoided. Looking at this slide here, that pretty MTM capsule gets my attention. And we're going to look at what are the 5 elements of MTM. The first thing you do is assess the patient, evaluate medication therapy, you develop and implement plan of care. And it's so cool as a pharmacist to get to sit back and develop and devise a plan for the patient's care. Of course, like I said earlier, documentation, follow-up, and monitoring. And follow-up and monitoring is so important because that is the only way you're going to know or double-check your work whether you constituted towards MTM outcome failures. And the slide shows this beautiful team of 4 people looking at a patient's report, how engaged they seem. And the kingpin in here is our lovely patient. CCDM. So CCDM is chronic care disease management. And this is a little bit different than the MTM. You know, people who constitute or take more than 2 to 8 drugs, or people who are into chronic disease states, which are expected to last at least 12 months or until death. It could be your patient with COPD, your patient with dementia, Alzheimer's. Any of those patients fall in that category for disease management. Actually, in some cases, even we have seen obesity fall into chronic care disease management because that is something that the patient is stuck with for the rest of their life. It could be their metabolism or genes. So anything that constitutes towards decompensation and functional decline will fall in the category of chronic care disease management. Now in the US, we practice this under incident to bill codings. We have a large amount of, rallies, I would say, going on in getting the provider status for the pharmacist, which I totally vouch for. The next one is health literacy and socioeconomic status. When you talk about health literacy, anybody who could have, say, a PhD in your IT field, or you could be a master in arts, does not necessarily have that level of health literacy. And people from different socioeconomic status will always face disparity in the treatment they get or the health treatment they get. So this is our role as pharmacists to increase the health literacy across the board for all the populations. When you talk about health literacy, there are a couple of elements that you want to keep in mind. Being non-judgmental, and that is my favorite one, and you're being patient-centered. In my practice, I had to deal with so many patients who were addicted to opioids. I could not be judgmental about the choices they made. One choice they made changed everything for them. So as a pharmacist, I had compassion and empathy and the drive to change them around by being non-judgmental. The other one I love up here is pillbox. And I always put myself into this example. I am just maybe, 40 plus, but I happen to have a busy life. And I'm multitasking as a mother, as a pharmacist, doing all the chores that one can imagine. And it's very possible there are some days I wake up and I forget, did I take my medication? Was it today or was it yesterday? If this is happening to a personality, I would call myself sharp and attentive and organized. But if it is happening to me, we just need to sit and visualize our population who is 60 plus or 65 plus, how difficult it is for them to organize and understand their pills. The other couple of things is always using large font in writing when you're talking to your population, older population, cataract, glaucoma, all of those factors affect their reading. Setting alarms to take the medication, avoid any medical jargon that will confuse them. You always want to use simple language and their preferred language. And this interests me so much for India. We have unity in diversity, and we have so many different states speaking different languages, and MTM rolling out in so many different languages would be so interesting. The end part of doing a CMR is MAP goals. MAP is Medication Action Plan. So you talk to your patient, you came to a conclusion. Now, what are the things that you want to put in that MAP goals? Did you make sure that the patient had ownership and engagement in disease making? If somebody wanted to quit smoking and you were just rambling about, smoking is bad and this and that, it's not going to hit the patient until the patient himself has the willingness to change. So give that ownership to your patients. Actionable steps, of course, if the patient was smoking, you're not just going to tell them to go call it as a cold turkey and give up smoking. It has to be attainable and it has to be actionable. The next one is medication safety, where you look at the different dosages that the patient takes, and you want to make sure there is not a high dose or a drug that was not supposed to be given to the patient. Reduce cost and drug waste, and this is so important. A patient could buy a medication and take it for about 4 or 5 days and realize that he had some kind of side effects or adverse drug reaction. What happens? Those particular pills are a drug waste. And so as a pharmacist, you can help them make choices and understand, the drug effects or why a particular medication is not working or if they need to prolong the therapy. The next one is Beer's criteria, which we utilize the start and the stop tool. And this gives guidance to our doctors where they are not allowed to prescribe certain medications for people who are 65 and up to reduce the falls in our elderly patients. Drugs like your benzodiazepines, long-acting benzodiazepines, they all fall in those categories. And of course, like actionable steps, you have to make smart goals. If you make a goal that is at point A and you want to go to point D and it is not achievable, the gap in between those goals is going to be filled up with frustration and depression. So you always want to make achievable goals. Now coming to the CMR process, you're talking about the techniques of communication that we use. And this is my favorite one because motivational interviewing is what physicians utilize in the United States. And it is so cool. If you go and research a little bit more, you can apply motivational interviewing to your personal lives. You can just solve any problems just with those techniques. I would highly suggest every student on here today to go research those videos. When you're talking to the patient, setting the stage is so important. Having that eye contact, the way your posture and how you're talking to your patient. A very simple fact that if the patient is cluttered into a small room, research suggests the patient may not be comfortable to open up and talk about their disease stat. Data from all different pharmacies and labs need to be collected, and your communication style with open-ended questions. This is so important. If you were to ask a patient, did you take your medication last night? The answer you're going to hear is yes or no. We do not want to have those kind of answers. We want to elicit the information that is in patient's health. If you forgot to take your medication last night, would you tell me what is stopping you from taking the medication? Now, this makes the patient open up and say, hey, you know what? I just like the show in the evening and I get so engrossed watching the show that I forget to take my medication. And you can come up and devise solutions in those kind of scenarios. Patient priority and DTP. And this is so cool. You might run into a patient who is the completely broken picture. You have 10 different things to fix in that particular patient. In this case, you do not want to bombard the patient with all the information you have. You want to prioritize the most important DTP that you're going to address with the patient. And that will be in which the patient himself is involved. The last one is MD communication. Yes, our MDs are busy. They're always watching the time clock with the amount of patients they see. So your communication needs to be confident, positive, assertive, research-based, but make sure you do not sound arrogant or condescending if you spot an error that an MD had made. So that is teamwork. That is how you earn the respect. Let that MD look forward to working with you. Let him have a smile on the face. Oh, I'm working with this pharmacist. Half of my work is done today. So now I say about emotions, philosophy, everything. Well, what is the science base behind it? A lot of studies, meta-analysis that were done shows us the positive outcomes. In patients suffering from diabetes, reduction in HbA1c levels was seen. Patients having hypertension, they understood the concept well enough, and there were reduction in 10 to 20 points in reduced systolic blood pressure levels. Congestive heart failure, that is so close to my heart. I lost a family member, and I always sat back and thought, what could I have changed? Every single student who's hearing me today, go home and get involved into your family and see where you can educate them. Patient safety, of course, it reduces ADR and improved adherence and HADIS measures, which is health information, data information sheet measures. Now looking at this particular mnemonic that says stroke signs. Face drooping, it says fast. Face drooping, arm weakness, speech difficulty, time to call 911. I have such a cool example to mention over here. There was a friend of mine whose dad had stroke, and he was empowered with the knowledge enough that he drove himself into the car to the hospital and he got timely treatment. I had another friend whose dad had symptoms of stroke in the night. They failed to realize what was going on with them, and by morning, they were declared dead. So just look at the difference, how education can empower our patients to make correct decisions. And we as pharmacists have to abide and disseminate the information. CPR, very close to my heart. I believe every pharmacist should be CPR certified. In my practice, one morning, one of my patients was always, sharply dressed, corporate personnel walked in. I would love serving her. Did not look right. Her lips were pale. She was barely walking. And my boss was doing a review of that particular day. I just realized something is not right and she was about to collapse. And I thought, do I need to get into action for providing CPR to this particular patient? Of course, our 911 systems are very strong, and we made that intervention and called 911. Patient was taken on the stretcher. After almost a week or so, this patient writes me a testimonial that I played an important role in saving her life. Imagine, as you pharmacists, how much power you have. They say that the destiny that is destined will happen. But a step before that is Purusharth, where you can play a role and look at the situations where a CPR is necessity. Immunizations. This slide reminds me of my training. When we were first undergoing the training for immunizations, a lot of my colleagues were almost in tears. Tears because they had the phobia for needles. But fast forward that, up to 5 or 7 years now, every pharmacist is capable of providing those immunizations. In fact, in my practice, I have to tell you, Immunization was the time when I bonded the most with the patient because they were nervous about the needle and I could talk to them. I could make those children laugh when I was immunizing. So pharmacists, you are in position to take care of all the expanded vaccines. Talk about that in the COVID scenario. Just about a few days ago, I was looking at a CDC webinar, how they are visualizing that if the vaccine were to be released, how are they going to line up these patients? Is it going to be the pharmacy, hospital, nurses, contact tracing, throwing trends? So we need to be prepared. And I believe as pharmacists, we can become a strong health workforce in the times where COVID has grappled our globe. And as I speak, my family members are battling situations like that as well. The next one I talk about is professionalism. Me being somebody who always wanted to learn, I never found the pharmacy circle to be complete. And the certifications that I took made me feel like a complete circle. So continuing education is a part of your knowledge base. In pharmacy, new medications are emerging every single year. And that should be the criteria for you in advancement of your knowledge. And I purposefully put those two different pictures of mine, showing the larger bandwidth. Be able to be representable, corporate, sharp, metric-oriented, whatever it takes, and be able to be humble with that little white coat. I was doing a flu clinic. Humble, kind, and compassionate to your parents, to your patients. That is what a complete clinical pharmacist should look like. Now, in my last seminar on popular demand, I had prepared something based on an album, Breathless. The students ended up loving. It's going to deviate from our topic a little bit today, but that's how I look at the complete pharmacist picture. Once upon a time, there was a man who was sick, and he decided to go find a medication. He ended up stumbling into getting an API. He now decides to put into clinical phase trials 1, 2, 3, and also 4. Looks like the medication was showing promise. And now he applies for NDA and FDA gets involved. FDA approves the drug and HEOR and KOLs get involved into disseminating drug to the public. REMS and black box warning, everything came into the picture. The drug now flipped into the market, reaching to the community pharmacist. The community pharmacist now follows HIPAA and OBRA guidelines and also guides the patient on taking the medication. The patient feels comfortable and confident, aligns to the therapy, and ultimately feels better in about 7 to 10 days. So look at the complete structure here. The back end facing where the molecules are designed and the drug is designed and it hits the market and the REMS and everything that's associated with it, to the front facing where you're talking to your patient. You should be in a confident position to be able to talk at any aspect or any level of pharmacy. I believe that sounds like a complete clinical pharmacist, and a patient who has you would be the lucky one. With that saying, I'm coming towards the end of my presentation. Think outside the box. And this is the slogan I want to create. Every single student, as you think about this presentation, and if I'm able to leave an aftertaste in your mind, please, as you open the books that you read, just go ahead and think about the slogan that I'm reading this today, how am I going to serve my patients tomorrow? Simple example, if you were to prepare some food because your guests are going to show up, and it is refrigerated, but you fail to serve that food outside, it does not make any sense. And so your process of learning to the pharmacy school is that process of making food. And when you encounter the patient, is now your time to serve. And in other words, I would say, Gyan Dan, go ahead and disseminate the knowledge that you have collected over a period of time. And the mission, I think we already talked about this. Yes, this is a possible factor. We would need a couple of things to align this and make this dream come together across the globe. Any country is in position in applying the clinical pharmacist role. What we would need is a task force, committee, innovation, technology, finance, of course, team players, and regulations to make sure that our program succeeds. And we have a wonderful team back home. Pharmacy Council of India is under such great leadership. I've had an opportunity to know a few of you over a period of time. So I think that is the slogan I want you all to go home with. Think outside the box, think clinical. And that concludes my session. These are my references that I used. There we go, back to everybody.
You have to unmute, Narayana.
Yeah, thank you, Dr. Bhavana, for the wonderful presentation. It will be our first household experience of MTM, which given a strong mindset to become expert in this MTM, which is going to be motivational for our student and young pharmacists. And wonderfully, you elaborated the role, collaborative team, and compared with the organs and their coordination. That is wonderful. You have given the presentation. And about the all those elements of the 5 elements of MTM: accessibility, development, implement, documentation, follow-up, and monitoring. All this wonderfully you have given what are the important elements of this MTM, what is the philosophy and what is the outcome. And finally, wonderfully you advised the student pharmacists. That's what I want to appreciate you. Meta-analysis, what are the positive outcome, and educate the family first about the do's and don't do's, and even immunization. In this, I think our organizations has requested the Federation of International Pharmacies, President Dominic Jordan, to give training to our pharmacists on immunization, which we are going to be participate in future in this COVID-19. That's what efforts have been taken from the organizers and the leaders of pharmacy profession. So from Indian Pharmaceutical Association also we have given the representation, and even from Pharmacy Council also the representation has been given to health authority, concerned authorities also. Thank you for the wonderful presentation, and over to friend Danbal.
Yeah, thank you, Chair.
Danbal, question and answers. We are running shortage of time. We will
Sure.
send it to Bhavana Madam directly, and
Sure.
it will be uploaded to the website.
Sure, sure.
And we can go to the next session, please.
Yeah, thank you, Chair. Thank Dr. Bhavana for the excellent coverage on the MTM in the pharmacy practice. You have given some of the key points like patient himself, herself in the collaborative team is the initiative of the era for the medication therapy management. And also the basic health literacy is the need of the hour in the developing countries. And further, you also narrated about the philosophy, goals, outcomes, and the process of the medication therapy management. And patients use the medications in a more beneficial and cost-effective manner. And the clinical pharmacists earn the respect by providing the professional services. And finally, you touched upon about the CCDM, that is the chronic care disease management, which was very well briefed, which will help the pharmacy students better to understand the medication management. And also, you were told about the role of the clinical pharmacists in the present COVID-19 pandemic situation. And thanks for your final quote, that is the slogan, pharmacy slogan, think clinical. Thank you so much from the ISCP Convention organizing team. Thank you so much, Dr. Bhavana.